For the Year 2 Neurological Examination, I want you to demonstrate your cerebellar tests, your balance tests, your SMR testing for your upper and lower limbs, your peripheral nerves, and your cranial nerve examination. It's completely up to you which order you do these in. For each section, I want you to demonstrate that you can do the tests adequately and competently, and also demonstrate what a positive test would look like. It's a pass or fail exam, and I would expect you to pass every section to pass the exam overall. Good luck. I'm going to start with the cerebellar tests. What I would ask the patient to do is place their finger onto their nose and just then place their finger onto my finger and back to their nose. As I move it around, I'm just looking for any tremors or overshooting or undershooting as they do that, which would be indicative of a cerebellar problem. Then I'm going to ask the patient to pop their heel down their shin and then just off at the end, and the same on the other side. Then I'd ask the patient to pop their hands onto their lap and starting with the right hand, just alternate their movement between supination and pronation and then get quicker if you can, and then do the same on the left side and then do both together and just compare left and right. I then ask the patient to walk up and down the room. I'm just looking at free walking. Is there any swaying? Are there issues with balance? Then I would ask the patient to do a tightrope walk or sobriety test, again looking to see if there's any issues with their balance. Lastly, I would get them to do Rombergs. If I could ask you to stand up and just stand there with your eyes open for a minute, looking to see if the patient sways at all, and then ask them to close their eyes. When we close our eyes, we're taking the visual system out, and we're testing three things overall. We're testing the dorsal columns and the proprioceptive information coming into the cerebellum. We're testing the vestibular information coming from the ears, and we're testing the visual information, all forming part of that vestibular system. We're going to stand there and make sure that the patient doesn't sway by putting our hands in front and behind, just making sure that they don't fall over. Okay, take a seat back down. Then moving on to the SMR testing, so the sensory myotomes and reflexes. Starting with the upper limbs, we're going to look at the dermatomes. Starting here, C5 down the lateral aspect of the upper arm, C6 down into the thumb and first finger, C7 into the middle finger and down the back of the hand, C8 into the fourth and fifth fingers, and then T1 up to the medial aspect of the elbow here. For the dermatome testing, you will need a medipin and also cotton wool. Using the sharp end of the medipin, you will be testing the lateral spinothalamic tract. The blunt end is testing the anterior spinothalamic tract, and the cotton wool is for the dorsal column medial lemniscus pathway. Using the sharp end of the medipin, ask the patient to close their eyes and go through each dermatome and ask them to identify that they can feel the sharp sensation. Do the same with the blunt, and then do the same with the cotton wool. Then what you want to do is ask the patient to differentiate between sharp and soft and blunt. And then finally what you want to do is compare left and right. So does this side feel the same as this side? And just ask the patient to report back. Next you would test the myotomes for the upper limb, so resisted muscle strength. For C5, ask the patient to put their arms like this, and you're looking at the biceps, so just resist me as I pull down. And then C7 in the triceps, so resist me as I push towards you. And then place your hands like this and wrists up, and resist me as I pull them down. That is the C6 nerve root for wrist extension. Then what I want you to do is turn your palms up, and those middle fingers, just place them up like that, and that is the flexor digitorum profundus. And what I'm going to do is just resist as they do that. Turn your palms over, and here we're looking at fifth finger abduction, abduction. So just splay your fingers out and resist me as I try and pull them together. And that is T1. And then moving on to reflexes, the bicep reflex, which is C5. Just support the patient's arm, place your thumb over their bicep, and you're expecting the bicep muscle to contract and the arm to come up like this. So there's a little bit of a movement there. The tricep reflex, you would take the arm out to the side, obviously be aware of any shoulder problems that the patient has got, and tap on the arm, and you're expecting the arm to come out just like that. So that is C7. And then C6 is the brachioradialis reflex. Again, place your thumb about 4 inches up from the base of their thumb and tap, and you're expecting a little bit of a contraction through the brachioradialis muscle. Then moving on to the lower limb SMR testing, starting with the dermatomes. L2 comes across this thigh here, L3 down into the knee, L4 is down the medial aspect of the lower leg, L5 is down the lateral aspect of the lower leg and across the top of the foot, and then S1 is under the sole of the foot and up to the back of the Achilles. Then onto the myotome testing for the lower limbs. What I would ask the patient to do is lift their knee up towards the ceiling. This is L2, hip flexion, and compare left and right. Then I would ask the patient to kick away as I resist them. So this is L3. And then I would ask the patient to lift their feet up or toes to the ceiling, which is dorsiflexion, and that is L4. And then for L5, I would ask them to lift their big toe up. As I resist pushing down, that would be L5, and then plantar flexion, pushing the toes down towards the floor, again resisted, and that would be S1. Reflex testing of the lower limbs, you would ask the patient to hang their feet over the side of the bench and just make sure that they're nice and relaxed. You can do the Gendrasic manoeuvre where you get the patient to clench their upper limbs just as a distraction technique. And then tap on the patellar tendon, and you're expecting the lower portion of the leg to kick out. And then also testing the Achilles reflex, put a little bit of dorsiflexion through the foot and tap the Achilles, and you're going to expect to see that come down into your hand. Then moving on to the peripheral nerves of the upper limb. First of all, you've got the axillary nerve, which serves that military patch on the outside of the upper arm. It also serves the deltoid and teres minor muscles. Then there's the medial and lateral cutaneous nerve, which is responsible for the medial and lateral aspects of the skin. Then the radial nerve, which is responsible for the extensors of the arm and forearm, and also for the skin of the posterior arm and into the lateral 2/3 of the hand. The median nerve is responsible for most of the flexors of the forearm and all the muscles of the lateral palm. It's also responsible for the skin effect of the palmar surface of the lateral 2/3 of the hand. The last one is the ulnar nerve, which innervates the flexor carpi ulnaris muscle, which is responsible for wrist flexion and also ulnar deviation or medial adduction. It's also responsible for skin innervation of the medial aspects, the 4th and 5th fingers of the hand. Then moving on to the lower peripheral nerves, starting with the femoral nerve. The femoral nerve supplies the hip flexors and also the extensor muscles of the leg, and it supplies the skin over the anterior portion of the thigh and down into the medial aspect of the lower leg. The lateral cutaneous nerve is responsible for skin over the lateral, posterior and anterior aspects of the thigh. The obturator nerve is responsible for adduction of the leg and skin over that medial aspect of the thigh. The sciatic nerve runs down the posterior aspect of the leg and supplies the posterior muscles of the thigh, where it then branches into the tibial and fibular nerve. The tibial nerve is responsible for the gastrocnemius muscle, the soleus muscle and the posterior calf muscles, and also the flexor muscles of the ankle and feet. The fibular nerve, also called the perineal nerve, is responsible for skin over the distal anterior leg and also the dorsum of the foot. It's also responsible for innervation of the tibialis anterior nerve and therefore the extensor muscles of the foot and ankle. Moving on to the cranial nerves, the first cranial nerve is cranial nerve 1, which is olfactory. We don't test this routinely in clinic, but we could ask the patient if they have any problems with their sense of smell. The second cranial nerve is the optic nerve. We could start testing this by asking the patient to read a Snellen's chart on a wall about 6 meters away for distance vision, and then ask them to read something close up for visual acuity or near vision. Then we would go on to visual confrontation, which is testing the peripheral fields of the patient. I'd ask you to cover your right eye with your right hand. If you look directly at my finger and then tell me when you can see these fingers moving towards you. Yep. And then moving from a lower arc. And then what I would do is do the same stood from the other side. What I would also do is test for visual neglect, where you're testing the posterior parietal cortex. You'd ask the patient to look directly at you when you're stood in front of them and wiggle your fingers left and right, and then both together. And you would ask the patient to indicate which ones are moving. So just look directly at me and tell me which fingers are moving. And that's it. You can also use an ophthalmoscope for visualization of the optic disc, but that's not something that we're going to go into today. But with the ophthalmoscope, we can use it as a light source and look at the pupillary light reflexes. When you shine the light into the eye, that's recognized by the retina, where it then travels down the optic nerve, through the brainstem and back through the oculomotor nerve. So when I test the left eye here, the constriction of the left eye is showing me that the optic nerve is intact on that side and the oculomotor nerve is intact on that side. If I want to test the oculomotor nerve, I can look at direct and consensual pupillary light reflexes. I shine the light into the left eye and the left eye constricts. That is the direct response. When I shine the light into the left eye and the right eye constricts, that is the consensual response. So for the consensual response, when I shine the light into the left eye, the optic nerve carries that information down the optic tract to the brainstem, where it crosses over through the Erdinger-Westphal nucleus and onto the opposite side and down the oculomotor nerve for the right eye, causing the right eye, right pupil to constrict. For cranial nerve 3, we can also test the accommodation reflex, where I ask the patient to look at the tip of a pen and then look at the wall and then look back at the pen and then look at the wall. And what we're looking for there is pupil constriction and dilation, but also convergence and divergence of the eyes. Then we can do the smooth pursuit or H-pursuit test, where we're looking at cranial nerves 3, 4 and 6. That's the oculomotor, the trochlea and the abducens. Most of the movements of the eye are controlled by the third cranial nerve. However, intorsion is cranial nerve 4 and abduction or looking laterally is cranial nerve 6. So just look at the tip of the pen and just follow it. And we're just doing it in an H test or an H shape. And as they come into that abductive position, I know that that is cranial nerve 6. And if the eye intorts, that would be cranial nerve 4. Cranial nerve 5 is the trigeminal nerve in 3 branches. We test the somatosensory aspects. So you've got the ophthalmic, the maxillary and the mandibular branches. And again, you would use a medipin and you're looking for sharp, blunt and soft, same as you would have done with your dermatome testing through your upper and lower limbs. So just asking the patient to close their eyes, I would place the medipin onto their ophthalmic branch, their maxillary branch and their mandibular branch. Tell me what they can feel and also then compare left and right. I'd also then palpate their temporalis and masseter muscles and ask them to clench their teeth together just to feel that the motor aspect of that is working nicely. Then you can look at jaw deviation, so placing your hand on the side of their cheek and just asking them to push their jaw into your hand, and the same on the other side. And then finally the jaw jerk reflex, where you just place your finger onto the crease of their chin, ask them to gently open the mouth slightly and then tap the finger, and you're looking for a nice either no movement at all or a little bit of a movement through the chin. If the chin snaps up or the jaw snaps up, that would indicate an upper motor neuron lesion, or if it drops open, it could indicate a lower motor neuron lesion. Cranial nerve 6 we've already tested, which is the abducens nerve when we looked at eye movements. Cranial nerve 7 is the facial nerve, all to do with facial expression. What I would ask the patient to do is raise their eyebrows and then frown, and then also scrunch your eyes together, and then relax, and then puff your cheeks out and relax, and then purse your lips, and then lastly drop the corners of your mouth down. The muscles that we're looking at there are frontalis muscle, orbicularis oculi for the eyes, buccinator when they puff their cheeks out, the orbicularis oris when they purse their lips, and then platysma when they drop the corners of their mouth. Also, the facial nerve is responsible for taste to the anterior 2/3 of the tongue, and it's also responsible for salivation and sensation to the posteromedial aspect of the ear. Cranial nerve 8 is the vestibulocochlear nerve. We've already tested the balance aspect of this. Now we're going to look at the auditory aspect. You can test this through 2 tests, the Weber's and Rinne's. First of all, what you're going to do is just click your fingers either side of the ears or whisper and ask if the patient can hear. So can you hear this? And the same on the other side. And then you go on and do Weber's test if you get a positive from that. Weber's test, what are you going to do is sound the tuning fork. It's the small tuning fork, which is 512 Hertz. Place the tuning fork on the top of the head, and you're going to ask the patient if they can hear it equally in both ears. If it's louder in one ear, that would suggest a lateralization to that side, which could be indicative of a conductive hearing loss in that ear, or indicative of a sensory neural loss in the opposite ear. To distinguish between those two, we would then do the Rinne's test. Again, sound the tuning fork and place the tuning fork on the back of the ear, just on the mastoid process. You'd ask the patient to say, can you hear it? When they say yes, you'd say, tell me when you can't hear it anymore. When they say they can't hear it, you would then turn the tuning fork round, place that over their ear and ask them if they can hear it now. If they can hear it then that confirms that air conduction is better than bone conduction, as it should be. If bone conduction is better than air conduction in your patient, then that would be confirmatory of a air conduction problem. Cranial nerves 9 and 10 are the glossopharyngeal nerve and the vagus nerve. Here you're looking for the uvular lift or the palatal lift at the back of the throat. What you're going to do is use a tongue depressor, place the tongue depressor towards the back of the mouth and ask them to say ah, ah, and you're looking just to see that palatal folds lift. If you do get a deviation to one side, the uvula tends to deviate to the stronger side, which could indicate a lower motor neuron lesion on the weaker side. Also, you can test the gag reflex. Whilst you've got that tongue depressor in their mouth, you can just push it back a little bit further and look to see if the patient has a gag reflex. Also, cranial nerves 9 and 10 are responsible for speech and dysphagia. So has the patient got any problems with swallowing? Cranial nerve 11 is the spinal accessory nerve. For this, you would stand behind the patient and you're going to look at the difference between the trapezius and the sternocleidomastoid muscles. So ask the patient to shrug their shoulders up and hold. As you resist down, that would be the trapezius muscle, and relax. And then ask the patient to turn their head into your hand and then the same into the other side. And that's the SCM muscle. If there's an ipsilateral loss of weakness, that would be indicative of a lower motor neuron lesion. And if there's a contralateral loss of weakness, that would be indicative of an upper motor neuron lesion. Finally, for the hypoglossal nerve, which is cranial nerve 12, we're looking at tongue movement. What you would ask the patient to do initially is just open their mouth, and you're looking for any fasciculations, a little bit wider, any fasciculations or atrophy of the tongue. Then you would ask them to put their tongue out and move it to the left and move it to the right, and see if there's any deviation as well. With the deviation, the tongue deviates towards the weaker side as it's pushed across from the stronger side. What I would also then ask the patient to do is stick their tongue into their cheek and then resist you as you push against it, and the same on the other side. And that completes the neurological exam.